Lower cross syndrome, fascial restrictions in lliopsoas region. So to release the area of lliopsoas, we're going to provide fascial stretch. So we're going to do a crossed hand spread. Again, this is going to be indirect. I'm going to place my hand just superior into the abdominal region, being cautious of where my hand placement is, and my other hand just on the top of the femur, and I'm going to apply a directional pull opposite to both of my hands, waiting for a stretch of the tissue. This is an indirect fascial release. We're going to do this for 90 seconds or longer in order to create a stretch in that region. We're engaging the fascia, the fat, and the skin only. We can go from an indirect fascial technique to a direct fascial technique. Redraping our client. And we can provide a direct fascial technique by again creating a bit of drag just on top or superior to the ASIS using a palmar surface, and our direction will be from inferior to superior. We're going to engage the fascia, the fat, and the skin, and we're going to create a drag moving from inferior to superior, stretching the tissue. Slow rate, 5 seconds or longer, to create that stretch to the connective tissue. Again, our goal is to increase extensibility, decrease pain, increase joint movement, decrease trigger point activation, we can also do a skin roll. So we're going to anchor our thumbs, take our fingers, lift the tissue up, elevating it, and then directionally moving it, dragging it, keeping the elevation and the stretch to the tissue as we go, moving inferior to superior, slow movement. We want a skin roll for about 30 seconds or longer, depending on our area. And you're going to work within your client's tolerance. Skin rolling is often more sensitive for people. We can go in different directions to reduce the fascial restrictions in that area. If it's too painful for your client, you can return to indirect fascial spreading or direct fascial techniques. Region. So we're going to start with just a crossed hand spread. So we're going to engage the tissue. Again, it's the fascia, the skin, and the fat. And we're going to separate our hands, engaging that tissue and moving our hands in opposite directions until we feel a restriction in that barrier. We're going to hold this for 90 seconds or longer, looking for a release. This is going to decrease high muscle resting tone. It's going to increase our fascia extensibility, increase our joint play. It's going to decrease trigger point activity, and it's going to decrease pain. This is an indirect technique. Now we're going to move to a direct technique, which will last for 5 seconds or longer. So we can move from the inferior aspect of the thoracolumbar fascia and move superiorly, engaging that tissue with a slow glide, creating a bit of drag using your opposite hand so that there is a pull to the connective tissue in both directions as you do your glide. You can use the palmar aspect of your hand. Usually 3 passes will work. You can already see hyperemia. I can use my forearm, my elbow, my fist in an open fist between the carpal metacarpal joints and the phalangeal joints. I can engage this tissue from a superior aspect to an inferior aspect, again creating a bit of drag, palmar surface, moving superiorly to inferiorly. I can go in multiple directions in order to decrease the fascial restrictions. And I can do a skin roll, placing my thumbs close together, engaging the tissue, bringing my fingers in and lifting up the tissue with my fingers and picking it up, and then slowly walking my fingers as I continue to keep that tissue elevated and lifted. I'm going to do a very slow movement in this area. And you're going to find areas of restriction where you will stop and you can just create a bit of a SIBO to the tissue, waiting for a gentle release. Or you can create an SBO to the tissue, waiting for release. Movement is slow and should be done within your client's pain tolerance. If this is too painful for your client, resume your indirect and direct glide techniques. And isolate the tendon of the biceps femoris. We're going to palpate, look for the musculotendinous junction. Using our GTO, Golgi tendon organ release, we're going to provide an SBO, holding for 30 seconds or longer to create load on the tendon, which will decrease our tone or spasm of the muscle. Done. Lower cross syndrome, high muscle resting tone from adaptively shortened hamstrings due to the condition. So for the hamstrings, in this particular situation, we're going to use a GTO, Golgi tendon organ release, and we're going to do this technique usually on muscles that have longer tendons that are more accessible, or you can use it in areas like the suboccipital or at the ischial tuberosity. So in order to apply this technique, we're going to isolate and locate our ischial tuberosity, and we're going to provide enough pressure directionally into a SIBO along or underneath the ischial tuberosity to provide load on the tendon. We're going to hold this load for 30 seconds or longer, so body mechanics are important in order to maintain this position. And we're going to wait for release. This technique will decrease tone and decrease spasm in a muscle. Once we've released the load at the ischial tuberosity, we're going to isolate the musculotendinous junction of the semitendinosus and semimembranosus. We're going to move to the medial aspect of the knee. We're going to isolate the musculotendinous junction, and with moderate to deep pressure, we're going to provide an SBO in order to create load on the tendon, reflexively decreasing tone and spasm on the muscle. Holding this technique for 30 seconds or longer, till we feel a release. Lower cross syndrome, lliopsoas, high muscle resting tone and shortness. So we're going to lengthen the lliopsoas muscle located on the anterior aspects of the lumbar spine. So we're going to locate our lliopsoas by gently placing our fingers with our distal phalanxes in hyperextended positions and then just slowly engaging into the tissue in a small circular motion so that we move the contents of the stomach away and out of our region. Just looking for that high-toned muscle. In order to ensure that we're on the lliopsoas, we're going to apply gentle pressure on the top of her knee and ask her to bring her knee to her chest. And relax, and the muscle should pop into your hand. Once you're on the muscle, working within your client's pain tolerance, you're going to keep your fingers nice and flat in that hyperextended position, sink down a little deeper until you're on the muscle, and then you're going to move the leg into internal and external rotation of the hip so that we are facilitating a greater stretch to the muscle, particularly through internal rotation as your lliopsoas is an external rotator. We can further assist the stretch of this muscle by gently reaching underneath your client's knee, leaving her fully draped, and just bringing that knee into a slight coxal flexion and extension. You would repeat this until you feel a release in the lliopsoas muscle. Lower cross syndrome, facet joint irritation on L3 and 4. So again, to find our location, we're going to landmark coming up from the 5th and the 4th and the 3rd lumbar spinous process. Once we've found our lumbar process, we're going to move laterally about 1 inch to 1.5 inches, which is going to put us onto the posterior articulating processes of the transverse processes. We're going to be applying an anterior, posterior, unilateral vertebral pressure. So I'm going to just engage that tissue into a grade 1 distraction. And I'm going to start with a grade 1 oscillation, which is a high frequency, low amplitude joint mobilization, waiting for a decrease in symptoms. This is going to decrease pain and increase synovial fluid movement. I can come back out and grow into a grade 2 oscillation, which can sometimes be more comfortable. So I'm going to again apply a grade 1 distraction, and then I'm going to do a grade 2 oscillation, which is a low frequency, large amplitude oscillation, which will do the same thing, decrease pain and increase synovial fluid movement. Our goal is not to stretch the tissue at this point. Our goal is to decrease the pain and stay within the physiological barrier, not into the elastic barrier. And coming out of that, we can also apply a transverse vertebral pressure. So it's an anterolateral pressure in the same location, a grade 1 distraction, my pressure anterior and lateral, going into a grade 1 oscillation, again being high frequency, low amplitude. And releasing out of that, once a release of pressure or symptoms, and then grade 1 distraction, and go into a grade 2 oscillation, which is going to be large amplitude, low frequency, waiting for a decrease in symptoms. Lower cross syndrome, trigger point in the left quadratus lumborum muscle. So after we have warmed up our tissue with our neuromuscular techniques, we're going to glide along the tissue looking for trigger points in the quadratus lumborum muscle. The deep trigger points are going to be found close to the transverse processes of L2 and 3 and L4 and 5. A trigger point is going to be a jump sign or a recreation of symptoms. Once you've identified where the trigger point is, you're going to apply ischemic compressions and wait for a release of the trigger point or an indication from your client that the pain has reduced. Once you've received indication that it's reduced and felt a release, you are going to flush the area and provide a stretch to the tissue. I'm going to continue looking for a trigger point along the posterior iliac crest. And again, once I've found the trigger point on the posterior iliac crest, which is recreated by a jump sign or recreation of symptoms, I'm going to apply ischemic pressure from 20 seconds to a minute, waiting for a release of the tissue or until my client has indicated it has reduced. Always remember to work within your client's pain tolerance levels. Following the release of the trigger point, going to flush the area and look for another trigger point, which can be on the lower aspect near the 12th rib. Once I've found the trigger point, I'm going to apply ischemic compressions, waiting for the release, and then a flush. As my client is still supine or prone, and I would like to do a stretch on quadratus lumborum, I can provide a segmental stretch by taking the tissues and using my hands and stretching the tissues in the direction of the muscle fibers, holding the stretch for 30 seconds. I would then apply heat, moist heat, or send my client home with moist heat hydrotherapy.